In this lecture, I'm going to cover the electrolytes for this chapter. I have built some tables for you to use for studying, so I'm not going to go through each table with you, but I will talk about each of the electrolytes as we go forward. I will post the tables on Canvas for you to use for studying. Let's go ahead and get started. So let's start with sodium. The normal value for sodium is 136 to 145 milliequivalents per liter. Sodium is crucial for maintaining osmotic pressure and fluid balance, influencing hydration status and cellular function. It is the main cation of extracellular fluid. It plays a major role in maintaining concentration and volume of our extracellular fluids. It also influences water distribution between the extracellular and intracellular fluid. Serum sodium level reflects the ratio of sodium to water, not necessarily the amount of sodium in the body. Because sodium is the main determinant of extracellular fluid osmolality, sodium imbalances are typically associated with parallel changes in osmolality. So again, remember, sodium plays a major role in our extracellular volume and concentration, generating and transmitting nerve impulses, muscle contractility, regulating acid-base balance. And we'll get into more acid-base balance later on. That's next week's lecture. And then regulation of sodium is crucial for preventing hypertension and edema in patients. So we have to monitor very closely. And here's the table for your hypernatremia and your hyponatremia. So looking at higher levels of sodium and lower levels of sodium and what that looks like in your patient. So you do want to go through this and know these tables pretty well so that when the test comes, you know how to answer those questions. And here's treatment and diagnostics. So let's talk about a case study. So MH, she's a 62-year-old female. She was admitted with confusion and lethargy related to hyponatremia. So she has low sodium levels. Her husband tells you that she has had complaints of diarrhea over the past week and was drinking lots of water to prevent dehydration. So what caused MH's serum sodium level to fall? Well, a couple things here. So excessive diarrhea can cause fluid and sodium loss. Replacing fluid with just plain water can lead to a dilutional hyponatremia. So in other words, sodium loss is greater than net water loss. We want to make sure that we're just looking at the reasons for hyponatremia and then think about some of the other things, which we'll talk about on the next slide. So we're going to admit MH to the nursing unit, and you are going to develop an individualized plan of care, and we're going to identify some appropriate clinical problems for this patient. So what are some of the things that we're going to think about when we put together a care plan for our patient? Well, we know diarrhea and water can cause some electrolyte imbalance, so we're going to use that. Also, acid-base imbalance, possibly because of the diarrhea, a fluid volume deficit. Impaired cardiac function, possibly because of what's going on with that electrolyte imbalance. Impaired cognition, because she was a bit confused because of the sodium levels being lower. And then impaired respiratory function, because we also know that different electrolyte imbalances can cause issues with respiratory status as well. So let's look at some appropriate interventions that would help normalize our patient's serum sodium levels. And then how would treatment differ if hyponatremia was more severe? So let's take a look at it, and we want to treat the underlying problem. So water excess. So we're going to tell her to not drink as much water, maybe put her on a fluid restriction for the time being. We might use some medications to help pull some of that extra fluid off, such as our diuretics. And then with the abnormal fluid loss due to the diarrhea, we might need to do some IV fluids that are isotonic sodium containing. So maybe our normal saline for this patient. If it was more severe hyponatremia, then 3% sodium chloride could be used. But again, we have to be very careful when we are administering that. And most likely this patient would be in the intensive care unit. And then also, if we're concerned about abnormal fluid loss, then maybe withholding diuretics. So we really have to figure out a balance between the two. So just talking through some of those things. So let's take a look at a question here. So the nurse is administering 3% saline solution IV to a patient with severe hyponatremia. It is most important for the nurse to observe for what? So when we administer 3% saline solution with severe hyponatremia, it's important for us as nurses to observe for signs of fluid overload and neurologic complications, particularly osmotic demyelination syndrome. And why that is because it's a hypertonic solution. Remember, it pools water from the cells into the vascular space. It increases blood volume. So we have to watch for that overload. And what does that look like in our patients? Well, it could be pulmonary edema. So they could have dyspnea, crackles in the lung, pink frothy sputum. That is an emergency. Hypertension. They could have increased blood pressure from fluid shifts, bounding pulses, jugular vein distension, and edema. So if we are looking at this list, so we have decreased heart rate and blood pressure. We know from all that description that our heart rate and our blood pressure would be increased, not decreased. Prolonged QT interval and facial flushing. I didn't mention anything about that. Shortness of breath and increased respiratory rate. Okay, that's sounding like something that we already talked about and what we're watching for. So that pulmonary edema. Increase urine output and decrease urine specific gravity. No, that's not what we're talking about here. We're talking more about the fluid overload. So if I'm going to answer it, my answer is going to be C, shortness of breath and increased respiration rate. So again, remember, we have to administer this with extreme caution because of that dangerous intravascular volume overload and pulmonary edema that can occur. So we're watching for that volume overload and that pulmonary edema, which includes the shortness of breath and increased respiratory rate in your patient. All right, now we're going to move on to potassium. Normal values for potassium is 3.5 to 5 milliequivalents per liter. This is the major intracellular fluidcation, 98% in our cells. This is necessary for resting membrane potential of nerve and muscle cells, regulates intracellular osmolality, promotes cellular growth, maintaining cardiac and muscular function, so maintenance of cardiac rhythm. So if you ever have somebody who has either high potassium or low potassium, hyperkalemia or hypokalemia, you're going to think about heart. So if a question on NCLEX asks you about your patient who has hypokalemia and one of the answers has to do with dysrhythmias, you're always going to pick that because that's the major problem with this electrolyte. And then acid-base imbalance as well. And again, we'll talk about that next week. Where do we find potassium? Well, it's in our diet, protein-rich foods, fruits and vegetables, potassium medications if we need to replace them for our patients either orally or intravenously, and it's also stored in our blood. It is regulated by the kidneys, so the kidneys are the primary route for potassium loss. They eliminate about 90% of the daily potassium intake. Excretion depends on the serum potassium level, urine output, and renal function. So when serum potassium is high, urine potassium excretion increases, trying to get rid of some of that. When serum levels are low, excretion decreases. Large urine output can cause excess potassium loss. Impaired kidney function can cause potassium retention. An inverse relationship exists between sodium and potassium reabsorption in the kidneys. Factors that cause sodium retention, so low blood volume, hyponatremia, aldosterone secretion, can cause potassium excretion. So that's how that is related. And here is your charts for hyperkalemia and hypokalemia. Again, excess greater than 5 and less than 3.5 for your hypokalemia. And again, I'm going to let you review these on your own for the test. And here are the treatment and nursing and interprofessional care. Moving on to calcium. So normal values for calcium is 9 to 10.5 milligrams per deciliter. The function for calcium, so formation of teeth and bone, blood clotting, transmission of nerve impulses, myocardial contraction, and muscle contractions. Major source is from dietary intake as well. We also need vitamin D to absorb calcium. So if somebody has low levels of vitamin D, we need to make sure that we're giving them replacement of vitamin D to help with that absorption of calcium. Where can we find calcium? Well, it's present in bones and plasma. It's either ionized or free calcium. And then changes in pH in serum albumin can affect calcium levels. So the serum pH influences how much calcium is ionized or bound to albumin. A decrease in plasma pH, so if somebody has acidosis, it decreases calcium binding to albumin, leading to more ionized calcium. And then the opposite, so an increased plasma pH, your alkalosis, increases calcium binding, leading to decreased ionized calcium. So calcium's balance is controlled by the parathyroid hormone. It increases bone resorption, GI absorption, and renal tubule reabsorption of calcium. Calcitonin increases calcium deposition into bone, increases renal calcium excretion, and decreases GI absorption. So here is your chart for hyper and hypocalcemia. Hypercalcemia is a level greater than 10.5. Hypocalcemia is a level less than 9. And these are the things that you're going to be looking at for the test. So you want to review that and be prepared. Different tests for hypocalcemia. I wanted to talk about this for just a quick second. So you can see here from the picture, the top one there is called a Chefsteck's sign. Probably said that incorrectly, but that's the best I can do. This is the sign of contraction of facial muscles in response to just a light tap over the facial nerve in front of the ear. And then Trousseau's sign is a carpal spasm. It's induced by inflating a blood pressure cuff above the systolic pressure for just a few minutes. And then you'll see if that muscle spasms. And that is a positive sign for Trousseau's. Again, that is signs that you're going to see in somebody with hypocalcemia, somebody with low levels of calcium. So let's talk about phosphate for a minute. Normal values for phosphate is 3 to 4.5 milligrams per deciliter. It is the primary anion in our intracellular fluid. It's a critical electrolyte that's involved in energy production, bone health, and cellular function. It plays a key role in ATP synthesis, which is essential for muscle contraction, nerve function, and metabolism. Phosphate levels are regulated by the parathyroid hormone, kidneys, and vitamin D. So some nursing interventions or nursing assessments that we want to do for these patients is to monitor respiratory status. We want to assess for any muscle weakness. We're going to encourage phosphate-rich foods if they are in need of phosphate, so dairy, nuts, whole grains, meat, and fish. We might need to administer phosphate supplements, either orally or by IV if it's a severe case. And then we're going to monitor serum calcium levels because phosphate and calcium have an inverse relationship. So when phosphate rises, you would see a decrease in calcium. And here is your chart for hyperphosphatemia and hypophosphatemia. So again, you're going to review that for the test. So let's talk about magnesium. Normal value for magnesium is 1.3 to 2.1 milliequivalents per liter. It is the second most abundant intracellular cation. It plays a key role in essential cellular processes. It helps to regulate muscle and nerve function. It supports a healthy immune system. It keeps the heart rhythm stable, helps with protein synthesis, bone development, and blood sugar regulation. ATP, it's needed for that ATP production and use. And remember, ATP, the energy source for that sodium-potassium pump. Adequate magnesium levels are essential for preventing neuromuscular disorders. It ensures proper muscle relaxation and contraction, reducing the risks of cramps and spasms, which are critical for maintaining overall muscle function and health. That's all that one more thing about magnesium and what we have to be concerned with. So somebody who has issues with magnesium, you have to think about cardiac issues as well. So the one that comes to mind is torsades. You'll learn more about all of this during the summertime, but I just wanted to throw it in there right now. But we know somebody who is experiencing torsades, we're going to give them magnesium. So their levels are too low. So magnesium, 50 to 60% is contained in bone, 30% in cells, and then only 1% is found in extracellular fluid. The kidneys and GI system regulate serum magnesium. It controls the amount of magnesium reabsorbed in the ascending loop of Henle and distal tubules and absorption in the small intestines. Here is the chart for hypermagnesium and hypomagnesium. So our levels greater than 2.1 or less than 1.3. So let's look at a question and see if we can put all of these points together for one of our electrolytes. So we have a patient who is admitted with renal failure and an arterial blood pH level of 7.29. Which lab result would the nurse expect? So we have to go in a little bit further, and we have to understand that a common cause of acidosis, which is that pH level below 7.35, is renal failure. So it's affecting the kidneys. Changes in pH affect potassium balance. So in acidosis, hydrogen ions accumulate in the intracellular fluid, and then potassium shifts out of the cell to the extracellular fluid to maintain a balance of cations across the cell membrane. So with acidosis, it's associated with hyperkalemia, so a serum potassium level above 5.0 milliequivalents per liter. So when we read this question and it's asking us which lab would we expect as a nurse, and we understand now that acidosis is related to hyperkalemia, then we know that we're looking for a high potassium level within our answer. So if we're looking at these answers here, I know that C, serum potassium of a 5.9, is going to be something that I expect for this problem. And that's correct. All right, that ends it for the electrolytes. Again, I'm going to post the tables for you so that you can use those to review. You want to know hyper versus hypo. We're going to look at all the signs and symptoms. You're going to look at treatments, nursing interventions. If you have any questions, please reach out.